Thanks, Clement. My slide up there? Okay. You know, trabeculectomy still is the gold standard operation for reducing pressure after failure of medication. Surgical failure classically can occur at 4 levels. At the internal ostium, scleral flap, episcleral fibrosis, which is more common, and scarring at the conjunctiva tenons episcleral interface, which is the most common. Mitomycin and 5-FU are the most commonly used agents for antifibrosis. There are certain toxicities, been well reported. The blebs are thinner, the epithelium is more irregular, you can get breaks in the basement membrane, fewer goblet cells, atrophic and avascular stroma. And as Dr. Dada mentioned earlier, when you do a fornix-based flap, you can destroy the limbal stem cells at that site. Complications include bleb leaks, blebitis, and endophthalmitis, which are associated with thin avascular blebs. And so there's a current search for alternative modalities, including deep sclerectomy, canaloplasty, and minimally invasive glaucoma surgery. The Olagen matrix is a collagen matrix with thousands of little holes in it. It's a porcine collagen derivative, and it's designed to promote wound healing without using mitomycin. Basically, the fibroblasts grow through the pores, so that instead of either a thin avascular bleb that you get with mitomycin or a tangled scar that you get if you don't use any antifibrotics, which virtually nobody does anymore, you get kind of the fibroblasts growing through in columns and tangles, and it gives you a spongy bleb. The Olagen itself is biocompatible and is biodegradable. And now in this slide, where'd that go? Show me how to use the mouse on this. I have an Apple. Okay, in the top half here, you can see an Olagen bleb. The fibroblast can grow in and proliferate, and gives you a physiologic wound healing with a spongy bleb, as opposed to the use of mitomycin below, which kills the fibroblasts and gives you a very thin epithelium in most cases. And this non-selective cell death leads to wound healing with a thin avascular epithelium. So why use Olagen? What does it do? It occupies the episcleral area over the flap and prevents the collapse of the subconjunctival space in the early postoperative stage. We use a loose suture. You can't trabeculectomy, we use 3 sutures, we make them tight, we can do laser suture lysis afterwards. With Olagen, we do 1 or 2 loose sutures and then put the Olagen over the flap at the end of surgery, and that tamponades this flap, and it prevents you from getting an early flat bleb and hypotony. You can get hypotony, but the bleb does not get lost. You don't get a flat anterior chamber. And so the Olagen guides the fibroblasts to grow through the matrix, and it also acts as an aqueous reservoir by creating a buffer milieu to avoid hyperfiltration. Now, this is not my slide. This is a company slide just to show you the one loose suture that's being used here. And the Olagen, I have an Apple, so I can't figure out where the mouse is here. The old Olagen is in this slide. It was 4 millimeters high and 7 millimeters in diameter. That did not work well. Then we went to 2x6. We are now using a 1 millimeter thick, 12 millimeter in diameter Olagen. Okay? And I want to point out, as you see in the bottom parts 5 and 6 there, this is not the way to do a fornix flap. Okay? Everybody does fornix flaps this way, and that's why it got a bad name. You don't start 6 millimeters behind the limbus and suture it up, because you lose 2 millimeters when you do your suturing. The bleb elevates, and then your scar incision is right over the back of your scleral flap, and the limbal incision fails. Now, if this movie works right, you want to put this on, please, because you started. I asked you to be here. I want to show you how I do my limbus-based flap. I don't start 6 millimeters from the limbus. I start way back, 12 millimeters back from the limbus. Okay, and I make a small incision. There's not a giant incision that occupies 180 degrees. I use a 6 millimeter incision starting 12 millimeters back, so you don't get any scarring of the bleb. And I devised this conjunctival retractor, which allows you to bring. All right, basically that's enough. Forget it. we're doing here. Okay, what that does, and I can send you the movie if you want. I believe it's up on YouTube. Starting way back with a 6mm incision allows you to come forward, do your trabeculectomy, put in the Ologen, put in mitomycin if you're using mitomycin, and then suture way back with a running 9-0 Vicryl, and you get no scar tissue anywhere near the scleral flap. Okay. And it works very nicely. You don't lose limbal stem cells, and you don't get these overhanging blebs onto the cornea, to the vascular blebs. You get vascular blebs. You get a bleb like you see in the middle up here. But you can get other blebs. These are the top row are all mitomycin blebs. Sometimes they're vascularized. Sometimes they're thinner and cystic. But the limbus-based flap that I showed you gives you a much nicer, broader bleb. Down below, you see 3 typical Ologen blebs. Sometimes they're vascularized, but that vascularization does not seem to harm the filtration. What I do sometimes, if you have big ropey vessels crossing the bleb, is I'll just close them off. People get nervous shooting at a bleb. You don't. I use 0.3 seconds, 300 microns, and 300 milliwatts, and you can close off any large vessels crossing the bleb. And then on the right, you see an ideal bleb from Ologen. But again, you can see it's a little on the cornea because that was done with the fornix flap. All right, let me just run through some studies. Chen et al. Did a study in 2006. They used rabbits, trabeculectomy with Ologen in one eye and nothing in the other. Now look, forget if you trabeculectomy without anything in a rabbit, it's going to fail. Okay, they all failed, and in the Ologen blebs they had a 50% reduction. Su et al. Had a very similar study using rabbits. In human studies, you can use it as an adjuvant in primary trabeculectomy, which we've been talking about. You can also use it in deep sclerectomy, phacotrabeculectomy, to cover exposed tubes in patients with patch graft melts, and if you have capsule problems with implants, you can excise the capsule, revise it, put in Ologen, and close it over again. In human studies, there have been 3 studies on Ologen versus mitomycin. We went time because of the movie here, but let me just quote Cellino's study because that's the most typical one. He did a 24-month prospective randomized trial. Pre-op pressure was 31. Mean post-op pressure, there was no difference between mitomycin and Ologen. There was no difference between complete and qualified success. The bleb height was higher in the Ologen than in the mitomycin. The Mary study was similar. This Rosentreter study was a much smaller study. They used the old style implant, and I just want to mention that they had no additional treatment in the mitomycin group, whereas the Ologen group, and these were small groups, needed medical treatment, but the mitomycin group, 1 patient required surgery for a bleb leak, 1 for a large cyst. Now, there's a question of should you use Ologen and mitomycin. Theoretically, mitomycin kills the fibroblast, prevents them from growing through the Ologen and giving you a good bleb. Dr. Dada mentioned this morning he had done a retrospective study using mitomycin Ologen with good results. It takes longer for the Ologen to dissolve. He uses low-dose mitomycin. He uses 1 milligram per ml for 1 minute instead of the 4 milligrams per ml for 3 minutes that we use. The Min study was. I'm not going to go through these other studies. Here are just examples of bleb revision with Ologen. On the left, you see pre-op, and on the right, you see post-op after doing bleb revisions. So the caveats: you got to remember to do 1 or 2 loose sutures. Bleb manipulation is more difficult. Laser suture lysis is more difficult. You can use my lens or the Blumenthal lens. You can try suture lysis through the internal ostium or cut the suture with the needle. Releasable sutures is a very good alternative. Needle revision of the cyst can be more difficult. You have to try to push the Ologen out of the way. And one way to avoid some of this maybe is to place the Ologen not right at the limbus, but a couple of millimeters behind it. It's not going to make any difference in the size of your bleb. So to conclude, Ologen's a safe and effective alternative to mitomycin. It enables prominent, healthy, and a little more vascular blebs to reduce late complications. The surgical success rate is comparable to that of mitomycin. We are currently having an 8-center trial in the U.S., but further studies are necessary for all of the different uses that I've mentioned. Thank you.